medicine have helped people live longer with acute conditions. These advances increase their quality of life so they can spend more time with family. However, individuals with advanced life-limiting and life-threatening illnesses often face multiple medical crises, frequent hospitalizations, and other challenges. Today's Vital Living Forum is the first in a two-part series that explores how patient care is evolving. This segment will focus on the changes that are occurring within the hospital setting to better address the comprehensive needs of patients, including their family values and their beliefs. Our second show will explore patient care from an individual's vantage and what we as individuals can do to help ensure our wishes are honored at end of life. Welcome. I'd also like to welcome our studio audience today. I'm Katie Dagenais, and let's get started. Joining me are Jane Willis and Kathy Black, and Jane Willis is the Chief Nursing Officer of Orlando Regional Medical Center. She is responsible for executive oversight of nursing services at ORMC and serves as a member of the ORMC Executive Team and Nursing Executive Council. Jane currently serves as co-chair of the Orlando Health Adult Bioethics Committee and has served on this committee for 20 years. She has lectured and authored articles on bioethics and is a member of the Florida Bioethics Network. Kathy Black is the Chief Nursing Officer of Dr. P. Phillips Hospital. She is responsible for executive oversight of nursing services at Dr. P. Phillips Hospital and serves as a member of the Executive Team and Nursing Executive Council. Kathy is a 16-year member of the Orlando Health Bioethics Committee and past nursing leader of this group. Kathy has provided numerous lectures on bioethics, nursing ethical issues, and moral distress. Kathy serves on the Advisory Council for the University of Central Florida College of Nursing. Jane and Kathy, thank you so much for joining us. So let's go ahead and start at the basics. What is the field of bioethics?
Well, let's start with ethics. Ethics is a branch of the applied philosophy, and it deals with moral issues that arise. Bioethics is moral issues that arise in the healthcare profession, so it's specific to healthcare. It deals with right and wrong answers. It assumes that there are right things you can do and wrong things you can do, and it explores what happens when there is conflict in those decisions or there's more than one right or wrong decision to make, especially right decisions. If you don't have choice, there is really no moral issue that arises. So if your heart stops and you can't start it again, there's no moral issue that arises with that. Your heart stops and that's the end of your life. But in healthcare today, there is a lot of chances that you could have multiple treatments and you may have to make choices from more than one right answer or the best of many answers that aren't perfect. So that's when conflict arises, or you may need help making decisions, you may need to be more informed, and that's where bioethics comes into place.
Now, there are a number of cases that we've heard in the news media having to do with bioethics, but the field of bioethics actually began with the case of Nancy Cruzan. Jane, can you explain that case to us a little bit?
Sure. Nancy Cruzan was a name that I heard around my kitchen table growing up. It was a highly publicized debate that took place in the courts. And what happened with Nancy Cruzan is she was involved in 1983 in a motor vehicle collision which left her in a permanent vegetated condition. She had no higher functioning of her brain, and she was kept alive by good nursing care and a feeding tube. And her family wanted the feeding tube removed, and the healthcare facility that she was being cared for and refused to do that. So they took it to the courts. It went all the way to the Supreme Court, which denied the family removing the feeding tube, saying that there wasn't enough evidence presented. Later in the Missouri court system, the family did win the right to remove the feeding tube, but it was a long publicized battle that a lot of people watched play out in the courts. In 1990, the courts did rule that her feeding tube could be removed, and she died 2 weeks after a peaceful death. It caused a lot of people to think about end of life, what they would want to do in that situation. And we saw the rise of bioethics committees to deal with issues like this in healthcare after this case. We also saw the passing of the Patient Self-Determination Act in 1990, which established advanced directives, and many people wrote living wills and designated healthcare surrogates after the Nancy Krazan case.
So let's talk a little bit about, and in terms of in a healthcare setting, how bioethics is used. One of the biggest shifts I think we've seen is towards patient care teams. Can you explain to folks when we talk about patient care teams, what actually is going into the care of a patient?
Sure. In healthcare, 40 years ago, 50 years ago, even 60 years ago, healthcare was very community-based, local. You went to your community physician, you received care in the community, you saw the same person for every illness that you had in the family. You often knew them, you knew your healthcare team, your hospital was local. People passed away at home, with their family there, and all of that happened community. Now you tend to go, even if it is a community hospital, hospitalists take care of patients. Hospitalists are physicians that are based in the hospital. Your primary care stays out in the community and sees you. So you may be taking care of, there's intensivists in the ICU that specialize in critical care medicine. And so the care has changed. So your care team has changed. Then there's a nursing team. There's often a multidisciplinary team that takes care of you.
Yeah. And what role do families then play in this care team?
Patients come in and we focus primarily on the patient, but families do play a big part. They're the primary support for the patient while they're in the hospital, and many times they participate in developing a plan of care and helping patients with decision making.
And they're encouraged to do so.
Absolutely.
Let's talk about the particular need in Central Florida for families to be involved. Obviously, we have a melting pot of cultures. So I imagine it's especially critical to make sure that the entire team is involved, including the family members who are there.
Absolutely. I think that, and the family has a broader scope now too. Families are made up of all different people that are important to you. So there's diversity in the Central Florida area in who your family is. Friends sometimes play the important role of family member. We are a society that moves around some, so you may have direct patient family here with the patient, or it might be friends, it might be more distant relatives, but your family plays an important role in your health and your well-being, and also in decision making and how you respond to the healthcare team, and we need to address those issues as well. I always, Jane and I talk about this a lot, but we often talk about family. A patient doesn't come in, they come in with a whole group of people, and you're really treating a whole team of people, not just the patient.
Yes.
So let's go back to some of these cases that we can talk about. The U.S. Supreme Court determined the 14th Amendment gave patients the right to refuse medical treatment. So let's first of all talk about that. What exactly does refusing medical treatment, what does that include?
We base this on the principle of autonomy, and autonomy means that I have the right as a person to decide what care I would like or what care that I would refuse. And historically, medicine was very paternalistic. Patients came into the hospital and physicians determined what care they would receive. Now we view it a little bit different. We feel like patients need to have informed consents. They need to understand the benefits and burdens of different healthcare options. And if they choose not to receive a treatment, that is their right based on the principle of autonomy. And we allow patients to make those decisions.
And how important, when we talk about living wills, and you alluded to this, Kathy, how critical is it that folks are deciding what their choices are prior to maybe being hospitalized?
Very important. And I think that not only deciding for yourself, but also making sure that everybody around you knows what you want is very important. And I think that we'll probably touch on that multiple times through our discussions, but everybody needs to know what your choices are, because everybody on the healthcare team, your family, the physicians, the nurses, should be helping make decisions based on what you would want, not what anybody else would want. And so that, if you use that as the patient is always the frame of reference for decision making, it makes it a lot easier.
Let's go ahead and delve into a couple of the gray areas when it comes to bioethics and patients' right to refuse medical treatment. So let's talk about food and hydration. Can you kind of explain to us kind of what is included in that and what is considered as you're treating a patient with regards to food and hydration?
When you think about food and hydration, you think about someone feeding themselves or being able to drink. When a patient comes into the hospital, sometimes food and nutrition refers to artificial hydration and nutrition. And when I speak about that, I mean actually feeding a patient through a device such as a nasogastric tube or a permanent feeding tube, or hydrating them through an intravenous line in their vein, or through a central line with total nutrition. That then becomes a medical intervention versus a patient just eating or drinking. And so that becomes a choice whether someone would want to be hydrated or fed artificial. And there's a lot of emotion around eating and drinking, especially at the end of life. Families don't want to be perceived as starving someone. They feel like that would be a painful death, but a lot of misconceptions about that.
And there's choices too. When you can feed and drink yourself, you can make the choice to eat or not to eat. With some of the artificial means that we use, a feeding tube, those kind of things, that choice becomes a lot grayer because you can automatically feed through a tube, you can automatically feed through an IV. So it sometimes muddies the decision making for when do you stop feeding and when do you stop drinking. And making a choice not to eat or drink for a lot of families is a tough decision.
One of the other gray areas, antibiotics. Can you explain that to us?
Before World War II, many people died of infection. We didn't have antibiotics available. Now we have antibiotics that can fight infection. So the question becomes, at end of life, do we provide antibiotics when there's an infection? Sometimes you can treat an infection, but the infection is just one of the problems that a patient has. And if you have terminal cancer, for example, giving an antibiotic is not going to fix your underlying condition. So that's where it gets tricky. At what point do you stop giving artificial nutrition and hydration? At what point do you stop giving antibiotics? Those are questions that we have to deal with all of the time in the hospital.
It's what stage are you in your final journey? If you stop an antibiotic too soon or too late, it may not help. Or if you don't treat something and the decision might be made that you're ending your life a little sooner than you may choose. So it gets to be a very difficult gray area too.
Now, hospitals have established policies and procedures, correct, to guide patient care. Can you give folks a sense of where that's at, so that there is a process?
Sure, go ahead.
We have a number of policies, and as a member of the ethics committee, we review any policies on that have an ethical component to them. But there is withdrawal and withholding policies on whether you, how and when, and if you can withdraw or withhold, and how you make those choices of withdrawing or holding any treatment or diagnostic test. It's mainly treatments with withdrawal or choosing not to do something or choosing to do something. There are feeding policies. There is, we even have conflict resolutions and how to determine the appropriate medical interventions.
And a lot of these policies are based on law, Florida statute, and evidence-based practice.
Mm-hmm. In going back to when we talk about family, the communication is critical. So especially if a patient is incapacitated, unable to make their own decisions. And that's kind of where we go back to. I know we've said we were going to talk about this a lot, but healthcare surrogates and really kind of setting the stage for what the patient would want. But let's talk a little bit about the communication, because we're talking about communication between family members, between family and caregivers. How critical is that?
You know, I think back, I've been a nurse for a very long time, and I think back to the day where we had restricted visiting hours and we limited time that family members could be in a unit or be at the bedside of a patient. And we learned through the years that that wasn't the appropriate thing to do. We really encourage family members to be at the bedside to support the patient and be part of the communication with the healthcare team and help make those decisions. And so now we try to include the family in every step of the way with communication. Some of the things that we do to facilitate communication is that we have set times in the intensive care units where physicians round. We call them patient-family rounds. We include, with the patient's permission, for family to be at the bedside during shift reports so that they can hear what the plan of care is.
Mm-hmm. So a lot of open communication as
Absolutely.
well. And when you mention the ICU, I imagine it also it differs based on where the patient is. So are they being treated in emergency care, ICU, an inpatient room? How does that differ? Because obviously, when care is emergent, it's going to be a little bit different, but it's still part of that open communication process.
Yeah, it's providing the right treatment at the right time, and it's the intensity of treatment at that time. So the intensity of treatment that you get in an emergency room or in the ICU is different than on a general med surgical floor, and there's steps in between that, or on a cardiac unit. So where you get treatment and what the level of that treatment needs and the amount of intensity the patient needs at that time also depends on the involvement of the family. So as you move to the highest levels of care in the intensive care unit, the family time and visiting hours may take back seat to the needs of the patient at that time. But we try to move and facilitate the communication and the discussions around treatments and that kind of thing to meet the needs of each individual patient.
What would you say to family members who are listening, and potentially future patients, but to family members in terms of what they should be considering when they have a loved one and they may have to make these decisions for them, and just what they should know about what's happening in hospitals and kind of the overarching goal of the hospital?
I would say have conversations. Have conversations at home. Know what your loved one's wishes are, and be an advocate for your family member when they're in the hospital. Speak up, ask questions, clarify, write your questions down, so when the care team comes around, you don't forget them and that you can have them answered.
And know that you can ask questions, correct?
At any
Absolutely.
time.
Mm-hmm.
At any time.
All right. Well, it's time for a short break, and when we come back, we will take a look at how communication plans are implemented in a hospital setting. Be right back. Welcome back to the Vital Living Forum on patient care in a hospital setting. Before our break, we were discussing the importance of communication between the patient, family, and healthcare team. In this second segment, we'll explore how bioethics consults can help open the lines of communication. And joining us still are Jane Willis and Kathy Black from ORMC and Dr. P. Phillips Hospital, and our studio audience. So thank you all very much for joining us and staying with us here. Let's go ahead and talk about bioethics consults. And before we do that, I think we need to first talk about who's involved in that consult, because there's actually an entire bioethics committee that's involved.
There is. Bioethics committees came about when we saw changes in technology in medicine. We talked about some landmark cases earlier in the segment, but when we started seeing things that could prolong life, like dialysis and ventilators, we got into some bioethical situations. And there were recommendations that hospitals have a mechanism to deal with these bioethical issues when they come up. And actually in 1992, the Joint Commission recommended that hospitals have a mechanism in place to deal with these issues, and the advent of healthcare ethics committees or bioethics committees came about. So at Orlando Health, we have a bioethics committee that is made up of physicians, nurses, social workers. We actually have community members on there, all sorts of disciplines, and we stay current in bioethical issues. We provide education to other clinicians, and one of the things that we also do in that committee is we provide consultations when situations arrive in the hospital with bioethics issues.
And so, Kathy, can you explain from a bioethics consult standpoint, in addition to the committee, who else is going to be involved in that consult?
A bioethics consult, once it requested, has actually a number of people involved. Usually the patient, if they can be. Most of the time the family is involved. For end-of-life decisions, especially, a lot of times the family's involved. The healthcare team caring for the patient, and also the ethics committee members, anywhere from 2 to the entire committee, depending on the level of discussion that we're having at that time. And so it is actually one of my favorite parts of bioethics, because it has the committee go out and we actually talk to patients and talk to families and practice a lot of the learning and the policies that we review and those kind of things. So it's important.
Yep, go ahead.
And anyone can request a bioethics consult. Sometimes it's the patient themselves requesting a consult. Sometimes it's the family. Many times it's clinicians who are involved in the care and have some moral distress, or they have some questions that need to be answered. The consult is advisory in nature, so our recommendations aren't binding, but we do provide advice.
And this is all stemming from the importance of communication and the role that communication plays in the proactive approach to caring for patients. So let's go ahead now and step back. The stages of communication begin when a patient is brought into a hospital. So from an emergency room standpoint, how is that communication established at that point to then keep those lines of communication open throughout the patient's stay?
So I think when somebody goes to an emergency room, obviously it's not a planned event. They're going because they have something that is acutely happening with their health care. So emergency departments are usually rapid-paced, a lot going on with diagnosing what the problem was, and that's where it's very important that we keep the patient informed of what are the diagnostic tests, what are the findings, and what are the next steps in the plan of care. Are they able to be treated and go home, or is it something that would require an admission? So primarily in the emergency department, the communication will be from the emergency department physician and the nursing care at the bedside.
And when you have a life-altering either event, or a traumatic event, or you have a diagnosis that is progressing, questions start coming up and the communication can change. And sometimes the awkwardness of the change in conversation. So if you come in through the emergency room, everybody in the emergency room's goal is treatment, results of treatment, getting you out of the hospital, getting you back to your baseline of where you were before, walking healthy. And sometimes if you have an end-stage disease, that it progresses on and you enter into the healthcare system, and then your goals of treatment change. And sometimes it's subtle changes or it's life-altering, and the family and the patient, and oftentimes the healthcare team is left with questions on what's needed and what points of communication do we need to have. And it's sort of pulling together all the pieces of communication. And that's oftentimes what an ethics committee does, is it helps the team, and an ethics consult helps the team communicate better and sort of drives that conversation.
And as you mentioned, Jane, folks are not planning to come in via the emergency room. So I imagine there are a lot of issues that could come up, perhaps even just going from coming in for something that they may think is minor to then having it turn into something major, correct?
Correct. One of the things that comes up frequently in an emergency department is what we call a code status, whether or not you would want to be resuscitated if you would stop breathing or your heart stops. And if you have an underlying terminal condition, some people choose not to be resuscitated, and that would be a very important communication that would need to occur very early on from the family, informing the healthcare team what the patient's wishes are in regard to being resuscitated or not being resuscitated.
From the consult standpoint, let's go back to that. How does a consult get called? Who can call it? How does that look?
Anybody can call a consult. The patient can call a consult, the family, the healthcare team, and really anybody on the healthcare team. We have had physician consultants call an ethics consult if questions arise with the family's treatment in one area of their diagnosis. The nursing team can call physical therapy. Really anybody can call a consult.
Mm-hmm. And just because a bioethics consult is called doesn't necessarily mean that there's an ethical issue occurring. A lot of times we'll be requested to come and see a patient for a consult, and really what the need is just to facilitate communication. And all we'll do is pull together all of the healthcare team and try to improve communication. Sometimes it's just education that needs to occur. Other times it is a bioethics issue, and then we will pull a team together. Typically what happens is we will speak with the attending physician, we will review the medical record, we'll understand what's occurring with the patient, and then speak to the person who requested the consult to try to determine, is it an issue with determining who the appropriate proxy should be for the patient, whether the patient should be a full code or a do not resuscitate. Most of the time in the adult world, we're dealing with end-of-life issues, wouldn't you say, Kathy?
Yeah, and that's the majority of the consults that we get are difficult decisions at the end of life. I think the ethics consultative team also gives every member of the team, whether it's the patient, the family, or the healthcare team, a voice. So, and sometimes in the noise of treatment and end-of-life concerns, that voice can get lost. So I think it's really important that sometimes somebody coming in that is not part of the direct healthcare team, and that is, we always make sure that members of the consultative team, that there are people on it that have nothing to do with the care of the patient, because sometimes you can be the outside looking in, which is helpful and gives you a perspective that sometimes gets lost in the day-to-day healthcare of somebody who's extremely ill.
And I think the other thing that the bioethics consultants bring to the table is that they see these type of situations all of the time, so they bring expertise.
Mm-hmm. And an interesting perspective as well, I would imagine. What is the time frame for these consults? Are we talking hours, days? What is the length?
That's a great question. We respond within 24 to 48 hours, but the needs of the patient really sort of decide how we respond and what we do. So if it is, an eminent decision that needs to be made, or it's going to have effect on the care of the patient, then we would pull the group together quickly. And we have a 2 to 3 person consultative team that really can mobilize quickly. And then we can also mobilize the bigger team together really with a little bit more time. So it really, don't you think it comes up?
Sometimes there is an urgent situation. For example, I can think of a case where the bioethics committee was called because the patient's family was refusing a blood transfusion, and it was a life or death situation, and the medical team was struggling with that decision and needed some guidance. So that's an example of something where the bioethics committee would need to consult quickly and make a recommendation.
And it sounds as though, obviously many people watching today may now know about consults and that they can call a consult, but I would imagine you have a lot of patients and a lot of family members who aren't aware. How often does the hospital step in to initiate the consult?
I think more often we see members of the hospital team calling consults more than patients or families.
Okay.
And oftentimes calling them for a specific member of the family or for the patient. We are in a unique position in healthcare is we step into people's lives for a short time and develop relationships. So the healthcare team may be developing relationships with part of the family or developing a relationship with the patient and be talking to the patient about some of their treatment needs and wants. And so issues will arise and the healthcare team will actually call the consult knowing that the patient or the family needs a voice that is not being heard or...
Yeah. Nurses spend a lot of time at the bedside with patients and families, and one of the roles of nursing is to be advocates for patients. And because they're in this setting, they tend to recognize when there's a dilemma occurring or a need for a bioethics consult, and they'll speak up and request the consult on behalf of the patient and the family.
If there's a language barrier, what is done in that particular case with regards to consults?
We have at the hospital great language and interpreting services. So we can use live interpreters, we have phones that work, but we try to use our formal services during ethics consults. So if the family does not speak English and most of the care team does, we will bring in interpreters. And we use the interpreter process in our hospital so that we are clear about medical terminology and what's needed. And then family often has somebody there who can speak English and also knows them and can express their wishes, but we try to use the formalized process also.
You know, Katie, in addition to language differences, we have so many different cultures of patients and religions, and those add complexity to issues in the hospital as well. So we try to tap into other resources besides language resources with reaching out to clergy members that may be of the same faith or other community resources.
We have even in a number of times had our clergy reach out to the family's clergy, because I think sometimes making sure that messaging is done correctly and that we're reaching out appropriately. All of us go into, as ethics consultants even, or as members of the healthcare team, we all come with our own set of values and our own set of moral beliefs. And we may be asked to help a family make decisions with beliefs and issues that are different than our own. And so we have to, that's a big part of our education on ethics, is how do you deal with that? How do you deal with the issues that come up that are not what my actual issues are, and how do you help a family work through theirs? Because we believe in the United States very strongly in autonomy, and that people come from a place of their own values and beliefs, and they have a right to make decisions based on that.
And I would imagine too, when we talk about different cultures, even just words that folks may use, like yes. I mean, yes can mean very different things in different languages and in different cultures. And so it's about understanding that particular patient, their family, their beliefs that they come in with. Mm-hmm.
We find in many cultures that different people play the role of the decision maker, where perhaps a wife may defer to her husband or the eldest person in the family to make decisions. And based on the principle of autonomy, if I decide that I want my husband to make decisions for me, that's my right, but I need to make that decision. It can't just be that the husband's going to come in and make decisions without having the permission of his wife to do that. So we deal with a lot of complexities like that.
We do, and oftentimes that drives the consult. The healthcare team will, or the family or a patient will feel like they're not getting to make the decisions, or that somebody is not, their voice isn't being heard culturally. And so we do a lot of clarifying and pulling the right team in together and helping with facilitate that communication process. So.
And what about families that are having difficulty making decisions? Because I imagine that's a huge part where we're talking about who is making the decisions. What if they have a difficulty really coming to a final decision?
You know, that is a dilemma that we face all of the time with decision making. And what we try to do to support family members is say that we don't necessarily need for you to make a decision. We need for you to tell us the decision that the patient would make if they could speak for themselves. And sometimes that's helpful, especially if they have had those conversations with the patient and they can honor those wishes, but that helps.
I do. I think there's some peace in that too. I think there's peace in knowing that you've had the conversation and that you know what somebody would want and that you're making decisions based on what they would want, because it's a heavy burden for families to have to make decisions based on what they would want over the patient. And so I think helping families clarify that works really well. And it's one of the things that I really is a sort of a mission when I'm on consults. I want to make sure that the family understands that it's about what the patient would want and what the patient needs. And I think that there is a lot of peace to that. So.
All right, well, Jane and Kathy, we're going to be right back. Thank you for this very interesting conversation about bioethics consults. Very, very important information for people to have. And the bioethics consult is about building bridges of understanding between family members and the medical team. And it's a tool that helps the medical team understand a person's unique situation, their concerns, and their beliefs. And when we return, we'll discuss the ethical decisions that often arise at end of life. We'll be right back. Welcome back to the Vital Living Forum on patient care in a hospital setting. In our first two segments, we focused on the role that communication plays in patient care, and nowhere is this more true than at the end of life. In this third and final segment, we will explore some of the ethical decisions that are confronted at end of life. Jane Willis and Kathy Black are with us from ORMC and Dr. P. Phillips Hospital, and we have our studio audience as well. Thank you all for joining us and being with us for this final segment. So let's go ahead and start. Jane, if you could explain what are the principles that guide end-of-life care?
Well, I think we mentioned this several times in the previous segments, that autonomy is very, very important, especially in Western culture, that we truly believe that we should honor the patient's wishes, that they have self-determination. We also use some additional principles. We want to do good. We want to prevent harm. We want to avoid prolonged suffering.
And pain and suffering and the relief of pain and suffering is the primary goal, right, Kathy?
Absolutely. And it's a main focus of the ethical principles. Maleficence means do no harm, and quality of life falls into that. Pain and suffering and relieving symptoms is very big at end of life. And some of the treatments that we do cause suffering and pain. Some of them we have answers to, some of them we don't. And sometimes if the goals of treatment are such that, you know, it's worth being treated and going through some pain and suffering, and the goal at the end of it is you're going to be cured and walk out, then we have medications for that and we can move forward with that. But sometimes what we do causes pain and suffering and we aren't going to be able to relieve it. Not so much the physical pain, but the pain of end-of-life decisions and the pain of having to decide what the quality of life you're choosing is. Very important.
I would imagine that, as you're working with families and patients, there are many cases when they want to pursue all medical options, correct?
Yes, absolutely. I think that everybody wants their quality of life to be the very best, and we do see a fair amount of consults on even differences of opinion in the family or the patient on what that means. You know, when do you quit looking for the cure, and when is your healthcare team recommending that you go for a more palliative process, or that you look at quality of life, your quality of life. One of the challenges that I've found even doing ethics consults is that we oftentimes, I think, don't bring in palliative care, which is the relief of symptoms, and we don't bring in hospice soon enough, in that goal for a cure that's probably not going to happen, and that the challenge is how do you find that balance between the two, and when do you decide? And it's a patient decision and a family decision and a healthcare team decision,
and very individual.
And let's talk about this word palliative. What is palliative care, Kathy?
Palliative care is the science of relieving symptoms. It is a large growing field in this country, and there is palliative care units that are specific to relieving symptoms and improving quality of life, and providing comfort and giving people the best possible outcomes on symptomatic diagnosis and treatment. Pain, nausea is a big one that is often treated in palliative care.
What is the difference between palliative care then and hospice care?
They overlap a little bit. Hospice care is really, typically people think of it as when you're in a terminal state, when you have 6 months or less to live. And part of hospice is palliative care, treating pain symptoms. But sometimes palliative care can be when you're still pursuing a cure and being aggressive with care. Palliative care can help with symptom management.
Do you ever find that families and patients may be resistant to the palliative care?
I see more resistance with hospice care because I think hospice care people feel like they're making the transition from hoping for a cure to knowing that they're in a terminal situation and at end of life.
And I imagine that's such a turning point for families and for patients, I would imagine, is making that decision.
It is. I think that in the pursuit of a cure sometimes, that quality of life gets lost in the discussion. And hospice helps with that because their focus is on improving the quality of the end of your life. And that's a journey all in itself too. And hospice is a journey. And sometimes when you start talking about the ethical issues that arise in healthcare decision making, it can be when to get hospice involved and when to stop that road to cure, and improving the quality of life of the time you have left. There's a lot of studies out there that show that patients that pursue hospice care actually live longer than patients who don't. So you can not only improve your quality of care, but that quality of care, improving your quality of care, makes you live longer.
Yeah. Mm-hmm. So let's kind of go to a different angle here. There's some conflict points, I would imagine, with regards to end of life in a hospital setting. We've talked a little bit about hydration and food. Can you speak to hydration and food? Are those considered medical treatments within a hospital setting as you're dealing with end of life care?
When they are administered artificially, as I mentioned earlier, through an IV or through a feeding tube, those are considered medical treatments.
One of the other challenging topics is ventilation, correct, Kathy?
Yeah, ventilation, artificial ventilation, somebody breathing for you, is one of the final steps in decision making at end of life. Is when do you stop those treatments? There are some treatments that you can start and stop. Dialysis, where you work the kidneys, where a machine works your kidneys for you, also can be start and stop. Food and hydration is not so final. But when you start talking about a ventilator, you start talking about that in itself can have ramifications immediately if you stop it. An interesting thing about dilemma that comes up with things like the ventilator is that the ventilators in and of itself do what they're supposed to do. So we often hear families say, well, the ventilator is helping them breathe, it's working. And it is working for a time, but it is not part of the treatment plan for long-term cure. So it sometimes puts off what's happening, but it's not a curative process. It doesn't mean that when they come off of that they're going to get better. And that is a very difficult concept, I think, sometimes at end of life. We do things that are doing what they're supposed to be doing, but are they benefiting the long-term care and treatment of the patient and the plan of care?
When should these conversations be taking place? Because obviously we're dealing with very, very difficult topics. And you've mentioned a number of examples where families and patients are it's a very difficult topic for them to discuss. When should these conversations be taking place? And when do they take place in the hospital setting?
We ask patients on admission to the hospital if they have an advanced directive or a healthcare surrogate. So immediately on admission to a hospital, whatever you're coming to the hospital for, those questions are asked, and we need to continue to have those conversations. Patients' conditions change during the hospital. So during the entire continuum of care, we have to continue to communicate. It's not a one-time event and then you're done, because I can be placed on a ventilator because I have pneumonia, be treated with antibiotics, and can be removed from the ventilator and do well. And so I may choose to be placed on the ventilator because I've got something that can be treated and I can have a good outcome. When I'm placed on a ventilator and there's no hope whatsoever that I could ever be removed from the ventilator, then it becomes life-prolonging. And sometimes life-prolonging procedures prolong suffering. And so then a conversation would need to occur with my family if I'm not able to communicate. Would this be something that I would want? Would I want my life prolonged in this manner?
How important are advanced directives?
I think it's, just how Jane just discussed, I think it's the most important decisions you can make before you get into the hospital. Because when you get into the emotion of the time when your condition's changing or you're no longer able to speak for yourself, it's your voice. And we've talked a lot over the last couple of segments about having a voice, and it is the voice of what you would want. Could you speak for yourself? And that's what advanced directives do. So I think that the conversation happens. It's why it's one of the first 5 questions, I think, when you sign your consent for treatment coming into the hospital. It's one of the first 5 questions we ask is, do you have an advanced directive? Because starting that conversation as early as possible gets you the best quality of life at the end of your life as possible.
And when we speak about advanced directives, there's 2 components of that. One of that is designating who you would want to be your healthcare surrogate. In the event that you can't tell us what you want, you would have someone who could speak for you. And that's a very important decision, is to choose someone to be your healthcare surrogate that would make the decisions that you would want. And the second part of an advanced directive is your living will, which I think people typically think of. That tells if you're in an end-stage condition or in a terminal condition, would you want to have be placed on a ventilator? Would you want to have artificial nutrition and hydration?
And that's why communication with the healthcare team is so important, and advocating and advocating for the patient if you're the healthcare surrogate, or advocating for yourself, or having those discussions with the healthcare team. Because over a hospital stay, even in a very short time, we need to build the trust that the information we're giving will allow you or your family to make the very best decisions possible. And that some of those questions that you have come up will be answered.
There's other things that I think are important to have conversations about. One of those things is organ donation. Would you want your organs donated at the end of life if you become eligible to be a donor? And I think we get that question asked of us when we sign up for our driver's license, and many people make an advanced directive of wanting to be an organ donor at end of life, and that's designated on their driver's license.
And I imagine when there are not conversations about what to do in an end-of-life situation, it can be problematic. How does the hospital handle that? If you find a patient comes in and there's really no plan, do you work with them to try to establish that plan so that their conflicts don't arise?
We try to provide a lot of resources. We have chaplains, we have licensed clinical social workers, patient family counselors that can support families with these decisions.
This is very, very important information for people. We've shared some fantastic information for them. And now we have some questions from our studio audience. So if we could, let's go ahead. Your question, please.
Yes, it's actually for either one of you, and it's pretty much a 2-part question. The first one is, you had mentioned in I think the first segment, about removing a feeding tube. When that feeding tube is removed and the person lives for a certain period of time, is there any suffering? Is there any, I know 5 minutes after I've had lunch, I'm hungry again. I mean, once you remove that tube, or is the patient starving? And the second question is, you've also touched on that, is my parents had directives. My mother's condition changed. The directives in the beginning were, keep me going as long as I can, as long as I'm going to come out of this. Well, 3 years later, she was still on the feeding tube. She was still being cared for constantly and had no quality of life at all. How do you determine what point that is no longer a possibility to keep them like that?
Do you want to take that, Kathy?
I'll take the first part and you can jump in. Here's the gift that we've been given, that God gives us, is that He's created the perfect machine in our bodies. And when our body starts to shut down, there is a lot of work been done with hospice looking at people who are being artificially fed and hunger, and our hunger mechanisms shut down. So there is a lot of work being done looking at, are people hungry? Are we starving them? And it does not appear that that is happening. And our body releases chemicals that make us no longer hungry anymore when we can no longer feed ourselves, and our organs are slowing down. So in that, when we look at that from an ethical standpoint, we look at the treatment plan for the patient. Are they getting the right comfort measures? We give a lot of medications that help for the nausea or anything that you might be having. But our bodies also work with us at the end of life to create that.
It's interesting because there's a lot of misconceptions about feeding at end of life, and sometimes when we provide artificial fluids or nutrition, we're actually making a patient more uncomfortable. They have more secretions. The kidneys don't shut down, and when kidneys shut down, they produce a natural endorphin that helps with pain at end of life. So sometimes we're adding a burden to patients by feeding them when they're no longer, when they're in the active dying process. We use the term sometimes AND, which is allow natural death. And when natural death occurs, it's like Kathy said, our bodies just shut down, and there's the evidence tells us that patients don't suffer when they don't have fluid or nutrition.
And I know the second part of her question was with regards to directives, and how do you handle when obviously a patient condition may change, and how do you use those directives throughout the end of life time as it progresses?
I think the challenge with advanced directives is, first of all, an advanced directive is only activated once someone can't tell us what their wishes are. So if you're not in an end-stage condition or you're not terminal, then we continue to ask you what you want. And you can change your mind along the way. When you activate the advanced directive, it's not black and white. There's a lot of gray. And so sometimes knowing when to stop the tube feeding or when to remove the ventilator is problematic. And that's when the communication that we talked about earlier is so important. Working with the family, working with the entire healthcare team to make those decisions.
The other piece to it is that as you're getting cues from your physicians and you're asking the right questions and the healthcare team is directing, you'll see a change in what the patient needs, so in what your loved one needs, and so you start asking those questions, and it just sort of, you can give a reasonable amount of time, and if you're not seeing response to any of the treatments, you can start making those decisions. And it's a whole focus of the family then, and you have to sort of work together as a team to know when it's right for you and it's right for the patient and their needs. So.
And I think we have another question.
Yes. We're talking about an advanced directive that the patient during a normal life creates. And when that person goes into the hospital, how does the hospital know that there is this advanced directive? And how is the family considered when this directive is present?
Well, as I mentioned earlier, that's a question that we ask every time a patient's admitted to the hospital. Does your family member have an advanced directive? We request a copy of it, and that's included in the patient's medical record, we keep that and we can refer back to it when you come into the hospital and ask, has there been any changes in your advanced directives? Obviously, everyone doesn't have an advanced directive, so sometimes we have to ask the family what the patient's wishes would have been, the healthcare surrogate or the proxy.
Very good. Some final thoughts, Jane and Kathy. We've talked so much on bioethics consults, the bioethics committee. For the viewers out there, your final thoughts to them on dealing with end-of-life care and also being prepared.
You know, we're starting to stay in healthcare that we're making a transition from what's the matter with you to what matters to you. And that would be a final thought for me is that all of us need to listen to the patient, listen to the family, what's the most important thing, what are their wishes, and really look at the entire patient experience and the quality of care.
Kathy?
Couldn't have said it better. It was a great final thought. Quality of life and advocacy in when you are part of a family or a patient coming in, asking the right questions. I think communication, along with some of the points Jane made, is the most important. And I think that just having conversation and communicating with your healthcare team and remembering that we're all a team and that we all want what's best for the patient and that care is individualized and that every person has a little bit, brings something different into the healthcare team and needs to have their thoughts and their needs and their wishes respected.
Yeah. Mm-hmm.
All right. Well, Kathy Black from Dr. P. Phillips Hospital and Jane Willis from RMC, thank you very much for being with us. And a special thank you to our studio audience as well for their questions and for being here today. And thank you as well for joining us as we share how hospitals are working to provide care that fits the unique needs of every patient. In our second show, we will explore what individuals can do to ensure their medical wishes are observed. The Vital Living Forum is part of Orange County's Vital Living block on Vision TV. And for more information, please visit us on the web at www.orangetvfl.net or contact the Orange County Office on Aging at 407-836-6563. I'm Katie Dagenais. Thank you for joining us.
Good job.